Hi class, now we're going to move on to the medical inequality section. First off, we're going to look at lack of adequate care. So overall, in the medical field, there have been a number of studies looking at this increasingly over time. And we find that, just for some top findings, that women in pain are significantly more likely to receive prescriptions for sedatives instead of painkillers. Women who had coronary bypass surgeries were half as likely to be prescribed painkillers as men with the same procedure. Women wait 65 minutes in the ER for abdominal care treatment, whereas men only wait 49 minutes for the same issues. And women are 7 times more likely than men to be misdiagnosed and sent home from the ER while having a heart attack. So, as you'll note from some of the readings and videos for the week, there's discussion of this, right? In that women's heart attacks tend to manifest different symptoms. Okay, and so the fact that historically we have overwhelmingly used the white male as the standard body for understanding ailments means that a lot of times things are misdiagnosed. Okay. Similarly, female cancer patients are more likely to be suspected of abusing pain medications than their male counterparts. And so why does that happen? Why do all of these things happen? Well, it has to do with the very long-rooted ideas that women are overly emotional and dramatic about their pain levels. Related to that is the fact that women are actually overdiagnosed for mental illnesses that are actually physical illnesses but are treated as being related to things like hysteria or anxiety or depression. And so it may be an actual physical ailment, but instead is treated as if it's psychosomatic symptom. And women are also allocated less time in clinics, right? So clinics with doctors. So like you have, on average, the patient will be assigned a 15-minute time slot to talk to the doctor. And so a lot of times women maybe get that 15 minutes, but hospital staff have reported that men overall get more time than that because they socially push for that, right? So they say like, no, we're going to keep talking until we sort this out. Like, I'm not leaving until you give me, an answer or at least a direction to go. Versus women are socialized to not be as pushy because it's instead considered rude instead of assertive, right? That difference in language. And so oftentimes women are just not getting enough time and care to really sort out what's going on with them. So it's important to consider, right, like how does socialization tie into a lot of these, because one, there's the aspect of medicine in which they just aren't looking at the differences in bodies, both within and between genders, because of course differences in hormone levels definitely signify potential differences in the ways that diseases manifest. And so then we have slut shaming that occurs from doctors to patients, but particularly for doctors who do any kind of exams or discussion of like reproduction, safe reproductive health care, right, like pap smears, mammograms, things like that. So overall, we see that a number of women are treated badly due to the number of partners that they say they have been with. And this is very vague, right? Because if the doctor says, how many partners have you been with in the last, 3 months, 6 months, year, whatever the case may be, then if you say a small number, then they may not believe you. But if you say a large number, then there have been numerous reports and studies that have found that doctors often tend to, they'll do things like ask a person if they had considered if they maybe were a sex addict, but also that doctors have gone on to lecture them about morals while in the middle of exams. And for anyone who has ever had a reproductive health checkup, then you know that those exams are a very vulnerable time for patients. And so to be lectured about morals while the exam is going on is not healthy and it's not a safe environment in any way. Similarly, patients who are not having heterosexual intercourse have found that doctors will say, like, well, why are you here if you're not pregnant, right? Or they say, well, you probably don't have an STI because you're not with a man, when that's not reality, right? You can get STIs in a whole number of ways that are not related to heterosexual intercourse. But these stigmas kind of uphold within the medical professional over time. Similarly, if a person who is, say, like asexual and sex repulsed, or if they're celibate for any other reason, if they tell the doctor that they have not had any partners when going in for their kind of routine health checkups, a lot of times they're treated as if they're lying, right? So then they become infantilized in the fact that the doctor acts as if there may be a preteen who is lying about their sexual history, and therefore, right, they just don't take into consideration the traumatic experiences of the exams for patients whenever thinking about that. And similarly, some diseases tend to be treated as inherently tied to promiscuity. Of course, the big name one for this is HIV/AIDS, in that it's tied to this idea of particularly gay sex, but promiscuous gay sex, right? So having multiple partners, when in reality, HIV, you can get it from sleeping with one person who is unprotected, or if whatever protection you're using breaks or is inefficient, or any number of reasons, including not even necessarily sexual intercourse, but also just coming in contact with someone's blood in a way that potentially gets into, say, like one of your own cuts, or there have been cases of doctors who have gotten HIV because of, like, right, if blood somehow gets in their eye, because blood does jump or squirt sometimes, right, if something, if someone is cut. And so these are just things to consider, that diseases that are necessarily tied to promiscuity, and a lot of times doctors treat them as if they're tied to promiscuity, aren't necessarily the case. But a lot of times for women and trans and non-binary individuals, they are treated as if they've done something wrong in order to contract HIV, when all it takes is one partner. That's not tied at all to realistic portrayals of the ways that people just conduct relationships. Similarly, another disease that is sometimes related to promiscuity is HPV and cervical cancer. Because a lot of times HPV does not manifest in men, so they can be carriers, but then women can get really horrific cancers from it. And so there are a lot of cases of women being treated by doctors, by their oncologists, as if they were, say, unfaithful to their partner in order to have contracted HPV and therefore cervical cancer, when that's just not the reality, because your partner can be carrying it dormantly. Yeah. So, right, something else to think about is why, right, these social perceptions of how people get diseases that are not tied purely in fact, why do they continue to pervade in the medical profession? Okay, and so then on to maternal mortality. Several of the readings, or no, not the readings, but the extra readings and the extra if interested section, and some of the videos from this week talk quite a bit about maternal mortality. Right, so here we see across years maternal mortality, and then broken down by race. And so you see that overwhelmingly the two groups who have the highest maternal mortality rates are Black women, and Asian Indian and Alaskan Native. So, American women die in childbirth at a higher rate than in any other developed country. So that just means countries that are comparable to us in things like economics, medical access, things like that. So, while non-Hispanic Black women are more than 3 times more likely to have maternal death than white women in the United States, as you see, white and Hispanic women have significantly lower rates. And we have yet to fully understand why Hispanic women have lower rates, but it's also very possibly connected to the continued family structure of a lot of times. Like, you'll have multiple generations living in one house, right? So like a mother and a grandmother, and so they are there to help throughout the pregnancy and to really try to say like, okay, no, something's wrong. Versus if it's someone who is pregnant for the first time, they maybe don't know what's normal and what's not normal. Okay, here we have maternal mortality broken into 3 different types of states. So this is called the PRMR, which is the pregnancy-related mortality ratios. And so we have 3 equal groups, high, medium, and low, where the mortality ratio was predicted, right? So states who have a low mortality rate, states who have a medium mortality rate, and states who have the highest mortality rate. And so as we see, even in the states with the lowest mortality rate, the mortality rate for Black women was about 3 times as high as it was for white women, right? So we see in the lowest mortality rate section on the left, ratio of, so 9, it's hard to explain as a ratio, but essentially 9 maternal mortality deaths per white women versus 26 for Black women, right? And then we have at the highest range 17 for white women and 46 for Black women. And here we see the connection with age as well, in that inequities increase by age, with the disparity for Black and American Indian and Alaskan Native women older than 30 years old are 4 to 5 times more likely than their counterparts to die from maternal mortality. And so, for example, the disparity ratio for Black women compared to white women ranges from 1.5 disparity amongst populations who are less than 20 years old, right? Because that's when, that's just like a lower time, is like in your early, late teens, early 20s, early to mid 20s for having a child, unless of course you are small, right? Too small as in like underweight, as many teenagers are, right? So then that's this comparison for that range versus the difference of people who are over 20 years old, right? Over 30 years old, over 35 years old. See just the massive rise in maternal mortality for Black and American Indian Alaskan Native women. And here we have broken down by education, right? So of course maternal mortality is for those with less than high school education or high school education, right? Because that has to do a lot with access to doctors, essentially, because of the cost of our medical system. And so here we see with less than high school, maternal mortality is highest among American Indian, Alaskan Native, and Black women. And then for school, it goes up, in which Black women have the highest rate percentage, and then after that it continues. Okay, and for college graduate or higher, some of you may have noticed that the American Indian Alaska Native bar is not there. That is very likely because of a lack of data. Okay, so the mortality rate for Black women with at least a college degree 5 times higher. Okay, and moving on to transgender health, but I wanted to particularly bring back this idea of the fact that when I'm talking about in all of the maternal mortality cases, I'm talking about people who have the ability to give birth. Okay, not necessarily, and just not talking about the gender identity. So in that case, I'm talking about the ability to give birth because that is how the research is set up. Sadly, the research is not taking into account populations like trans men or non-binary individuals' births. But just know that that is a consideration. It's hard to work around the fact that medical data is collected on a binary scale. Okay, so moving into transgender healthcare. So trans individuals are more than 5 times the national rate, have more than 5 times the national rate of HIV in comparison to the national. Black respondents with HIV from this survey are 6.7% of the survey, and Black trans women respondents with HIV were 19% of the survey. Right, and remember that this survey, as per the beginning of the slide it had, I want to say 20-something or 30-something thousand respondents. So it's not a tiny number of people that we would potentially see like an inflation of the percentage if it was a very small sample. 39% of trans respondents reported serious psychological distress in the months prior to the survey versus 5% in just the OVAS population. 40% of trans individuals attempted suicide in their lifetime, and so that is 9 times the rate of the US population attempts, which is 4.6%. And 1 in 3 trans respondents had negative or just flat out refused treatment. And lastly, so 1/4 of respondents did not seek health care when needed of a fear of being mistreated, right? And this connects back to just the overall mistreatment of women, trans, and non-binary individuals in healthcare. 1/3 did not have access to healthcare because they could not afford it. And trans individuals with disabilities were 1/4 were unemployed,